children and families through our public financing systems. And I really want to share the background work that I've had doing this, and the particular honing in over the last half dozen years on the role of the child health practitioner and the work in the early years of life and their connections to supporting and strengthening families and all of the good work that you do. As I said, we have a Health Equity in Young Children initiative that has been a partnership of the BUILD initiative and the Child and Family Policy Center through funding from the Robert Wood Johnson Foundation. And we're continuing to do work on that with a particular emphasis upon the primary child health practitioner's role in advancing healthy child development and connecting up to and supporting family support in that process. My presentation is, I'm going to go over 4 things, and some of these I think will be very familiar with all of you, and it's my way of framing it, not only to the general field of people in the child advocacy, but also to health practitioners. And some of it will be more specific to where is this possibility for really collaboration and connection between what's emerging in terms of child health practices and what can then support family support. So the first part is going to be on just health equity as a framework for action in child health transformation. Then the particular importance of the first 1,000 days. And again, this probably won't be very new to you, but it's a way of we've done to kind of frame and suggest the very importance of focusing in on these years. The additional importance of place and race to health equity and how this really is around inclusion and addressing issues of equity from a racial perspective as well as from a gender and a socioeconomic perspective. And finally, the kind of the opportunity of family support in this work that is underway around child health transformation, and how you can support that and how that work can also contribute to yours. So the first thing is health equity as a framework for action in child health transformation. First is that the health field actually defines health quite broadly, more than just medical care and treatment. Child health is a state of physical, mental, intellectual, social, and emotional well-being, and not merely the absence of disease or infirmity. And healthy children live in families, environments, and communities that provide them with the opportunity to reach their fullest developmental potential. So the definition of child health has really moved from a focus on biomedical care to a much broader focus on healthy development. And health equity itself is achieving the highest level of health for all people, but it does entail focused societal efforts to address avoidable inequalities by equalizing conditions for all groups, and especially those who have experienced socioeconomic disadvantage or historical injustices. So there's a strong component around addressing racism, sexism, and other isms in promoting health equity and ensuring that we are inclusive and responsive in what we do. And the quote from Martin Luther King is really that not only the definition, but the imperative that really injustice in healthcare is the most shocking and inhumane of all forms of inequality, and something that we have a real obligation to address. In terms of what the health practitioner can and should do, and the health practitioner certainly cannot do everything, but particularly when children are very young, birth to 3, 91% of all kids experience a well child visit, and actually 55% of all kids have health coverage under Medicaid or CHIP. And this is the period of time when they average their most contact with a child health practitioner, 2.2 average well-child visits per year. This is where health practitioners have in really many respects the most contact and the most opportunity to serve as first responders to children and their families and provide guidance and support as an authoritative voice on healthy child development. And moreover, in this first 3 years of life, in fact, kids are by and large not in other systems. When you start talking about school-age kids, kids are in school, and there's a near universal point of contact where they spend 6 to 8 hours a day. But when kids are very young, practitioners have a particular role in the early identification and initial response to things that can contribute to young children's healthy development. Only 14% are in some form of regulated care. 4.5% receive public assistance. 4.2% have a child care subsidy. 3% early intervention. 1.5% are an early Head Start or McV, and 0.7% in foster placement. And all of those figures are well below the 20 to 35% of families that we know who are starting out, who face challenges and some barriers to providing that safety, stability, and support and nurturing in the home environment. And all families need support, but particularly families with very young children have that need for a supportive environment around them. And the child health practitioner can be that first point of contact and play that first responder role, and also can provide some opportunities for additional financing and support for family strengthening activities with families. Those are kind of things. So why are we looking at the child health practitioner, particularly around the first 1,000 days? In terms of the importance of the first 1,000 days, I think that there's been a lot of policy development around young children and the birth to 5 years over the last decade and a half, some of it borne by the brain research, which we'll get to a little bit later. But I like to distinguish between what happens in the first 1,000 days with the second 1,000 days in terms of children's development, because the first 1,000 days really are about bonding, trust, attachment, the child developing a sense of security with the world, really taking their first steps and speaking their first words and learning through these intimate serve and return activities. And it's here where the immediate home environment and the safety, stability, and nurturing that parents are able to provide is so critical. As you get into the second 1,000 days, you do talk about, I mean, it is very important in terms of socialization, learning in groups, developing higher order language literacy skills, complex motor skills, and certainly learning about gender, racial, and cultural differences in roles, and that group and intentional learning environment directed activities are important. But the first 1,000 days are really critical to how children become ready to see and view the world, and they deserve to have that world looking back at them and connecting through those serve and return activities. So like to place this is a particular role where family support and family strengthening is critical. And it's great that we've had a lot of work to expand preschool in the second 1,000 days, but we also have to have that connections in the first 1,000 days around children's healthy development. And this slide is another way of framing all of this for the policymaking world and for people who are in different fields, saying there's a wealth of research and knowledge about what produces healthy trajectories in those first 1,000 days. the protective factors literature from CSSP and your Strengthening Families work, adverse childhood experiences from the Center for Disease Control and Prevention, the resiliency literature, which is its own field, but it's something where now the American Academy of Pediatrics is having a particular focus on, epigenetics and the whole genetics research around the interplay in those early years really affects long-term and intergenerational development. Neurobiology, toxic stress from Jack Shonkoff, the Center for the Developing Child, and the social determinants of health. The understanding that it's not just biomedical care and a child's genetic conditions, but it is all those other social factors that affect health. That we have this wealth of literature across many different fields that all point to the same thing, which is, and in red, I often call this the parent science, that really, when we're talking about young children, we really have to look at it in the context of what can we do to support and strengthen families so that there is that safe, stable, and nurturing home environment. In the medical world, there's a lot of emphasis upon social determinants of health now. And I've taken 5 of those determinants that were established by the World Health Organization to sort of frame this work of moving beyond looking at medical care and clinical health conditions. And then just shown that there's almost a direct crosswalk between those and the 5 protective factors from the Center for the Study of Social Policy and the work that you do, that they point to the same set of needs. And so when you hear people in the medical community talk about social determinants of health, I think it's really important to recognize that you can do that translation to say that what you're talking about in terms of social determinants really are the same thing as what we're talking about when we're talking about protective factors. And in many respects, what the protective factors are framed as, this is what we do to address these concerns that we have in terms of stress, as we foster resiliency so people can respond to stress. In terms of social exclusion, we ensure that there are positive and supportive actives for children, and so on. So the conclusions from this parent science and the research on the role of families really is that, particularly in the birth to 3 years, parents are their child's first teacher, nurse, safety officer, and guide to the world. And they need additional support if their child experiences physical, developmental, social, or behavioral disabilities because of the stress that causes, that all families need support. And it's not just families which are struggling economically, but if there are things going on in the child's challenges, then families really do need that additional support. That the safety, consistency, and nurturing in the home and health and learning environment is what is critical and foundational to ensuring positive health trajectories. And when we begin to look at what our outcomes should be in the early years, you can't really say that kids are going to be doing well at age 3 unless they have that safety, consistency, and nurturing in the home environment. And if they do, you can be pretty sure that their development is going to be pretty good and fairly much optimal. And the third thing, that inclusion and cultural responsiveness in the earliest years are key to combating bias, discrimination, and devaluation, and that this really has to be looked at not only from the infant's perspective, but also from the parents' perspective, and that they're going to be better equipped if they do not have to contend with bias or discrimination, and that at least there are people who support them and recognize and value them in their role. And this last slide in this section, I'll just go over really quickly, is I think that whatever the social policy question is, that lawmakers may be asking today. What can we do to end poverty? What can we do to reduce chronic disease? What can we do to reduce school dropout? What can we do to reduce crime delinquency? Or what can we do to eliminate disparities in inequities? A very significant part of the social policy answer is making investments in strengthening families in the first 1,000 days. Well, I wanted to go over that and just give that as a backdrop as my way of framing this to people who are not necessarily in the family support field, but are in the medical field or in the policy field, to get them geared toward looking at health more broadly and looking at family support as something that is needed to achieve the goals that they have for children. I want to talk a little bit about the additional importance of race and place to health equity. That we know that poverty affects material well-being, but it also affects relative status and opportunity. Poverty causes stress and makes parenting that much more difficult. It's not absolute, do parents have enough to be able to provide for the basic needs of their kids, but does the toll of living in poverty and the sense that that provides them really take a toll on them as they try to be optimistic about their child's future and as they seek to provide that home environment where they do not feel under such stress that it's difficult to interact with their kids. And we have to recognize that young children of color are much more likely than white kids to experience poverty. And they also are likely to experience that in the context of discrimination, exclusion, and marginalization. That kind of further reinforces that that stress on family and makes takes a toll on parental resiliency as well. And that this also includes geographic segregation, and therefore many of the responses we're going to have to make are not just on an individual family basis, but they're really on a broader family support, community building response within neighborhoods and communities that really support families in being the advocates for their kids and being able to create the environments in their neighborhoods that their kids deserve. One of these things is the first thing I think we really do have to recognize is that young children of color are by far the most economically disadvantaged. And this chart just shows that while 16% of all white non-Hispanic kids live in poverty, the figures are more than double that for Hispanic and African American kids. And while a third of kids who are white and non-Hispanic actually live in households with 400% or more of poverty, which is 100,000 or more for a family of 4. That's 1 in 3. Only 1 in 10 Hispanic and African American kids do. So that this economic disadvantage has a very, very strong racial and ethnic basis that we have to recognize as we develop strategies and solutions. The second thing is that kids live in neighborhoods, and the neighborhoods themselves make a difference in what they see as opportunities, what their parents have in the way of opportunities, and so on. And we've looked at breaking down all of the census tracts in the country by child poverty, and the child poverty rate in census tracts go up. We found that poor neighborhoods are rich in young children, that when we look at our poorest neighborhoods in our country, they have half again as many young children and therefore need half as many family-friendly gathering points, activities, and supports. And they really are loci that we need to think very clearly around what do parents with young kids need to have in the immediate neighborhood that's going to support them and their children's development, and recognize that these are very young neighborhoods. When we also look at these poorest neighborhoods, they're heavily segregated. While neighborhoods with 10% or less child poverty are about 2/3 white, non-Hispanic, neighborhoods with over 40% child poverty are more like 85% kids of color. And while a share of white, non-Hispanic kids live in poverty, high poverty census tracts, almost 4 in 10 African Americans and more than 3 in 10 Native Americans and Hispanics do. That these neighborhoods are where many kids and almost a very significant share of kids are growing up. And these poor neighborhoods look very different than their more affluent partners. And this is just a comparison in terms of single parent families, in terms of adults who have college degrees or who don't have high school degrees, in terms of those people who may be role models, their career models, the prevalence there in terms of preschool participation, in terms of owner-occupied housing. These poor neighborhoods are much more neighborhoods where the amenities and the supports available to kids, young kids, are just not there. And we really do require looking at those neighborhoods from a perspective of how can we strengthen family support, how can we do neighborhood building, and how can we recognize that since so many of the families are families with young kids, we have to create opportunities and activities that really are focused on what we can do with young children and families. Clearly, that speaks to having family resource centers, parenting education programs, family support nights, cultural activities and the like. But I wanted to bring this up because these are also neighborhoods which are generally served by, in the healthcare system, by federally qualified health centers or community health centers that also can be hubs for activity for some of the work in those neighborhoods. Say these neighborhoods, families want their kids to have opportunities for success and really are making sacrifices to that end, given the pathways to get there, but they offer far less in the way of pathways. And building those pathways possible, but it does involve additional investments. And it's here that I'll speak to a little later where the health system can play a role in this work, particularly because of its presence in the community. With the faith community, it's often the healthcare community that is something that is visible within the community that young children and families can access. So now I want to get to the fourth point of, so where are the opportunities for family support in child health transformation? And I think that one of the things that we've really been working on with the Center, with the Health Equity and Young Children Initiative, has been to work with people who are champions in the child health practice field, particularly those who are doing primary care and performing well child visits, about what are they doing that is moving beyond giving vaccinations, weighing and measuring kids, and dealing with illnesses or injuries, to really promoting healthy development. And Bright Futures came out with its latest edition as far as guidelines for well child care from the American Academy of Pediatrics, which is also, because of the the Affordable Care Act, the law of the land of what should happen in primary care. Bright Futures is really placing a great emphasis that child health practitioners can be that first contact with families and can and need to provide support to families that goes beyond medical care, and that includes linking up and connecting to other services and supports in the community, and responding to what are things that can be barriers to healthy development. And on the right-hand side are a number of different either programs, many of which are now being replicated in multiple sites, or institutional settings where a community health center or a hospital has decided to take on the role, which have really moved primary child health practice beyond the medical world to supporting families and operating in a well-child way that does begin the process with the practitioner in the office of providing guidance and support to families to strengthen families. That also goes the next step of a really effective warm handoff to somebody who can provide that further response and family care coordination, family advocacy and support, which validates the family and also helps to have the family better access what's available in the community and community resources that then exist in the community. And this is kind of a framework that is emerging in the field, and I think now in every state there are practitioner champions who are adopting this as what they're doing with their health practice, starting with the child health practitioner as that first responder and really looking at the parent as their child's first nurse, safety officer, and teacher, and looking to what can I do to support them in their role, in these roles, and to identify if they have stresses, what I might do in my practice to provide some relief from that. But as importantly, how can I make sure that they have contact with somebody who can spend the time and develop a relationship and engagement with the family to provide for that further identification of what the family wants and needs and follow-up care coordination navigation. And it's listed here as care coordination navigation, but the practices themselves recognize it's much more than what most people think of as being care coordination. And what it really requires is somebody who does have the values and the skills of a family support worker or specialist or a promotoras, an Obrando Puertas, or a community health worker, or somebody who really does connect up and link with families. And then the third piece is that engagement with and linkage to what can be helpful. This is probably a little bit hard to see on your slide, but the top set of circles are sort of the more professional services, and there's certainly, you identify a mother who has maternal depression and you want her to receive care and mental health treatment for that. And if the child has a developmental disability or delay, you want to have Part C able to respond to that specific developmental disability or delay. But as important are making sure that the family is connected and integrated and has a support system around them that can provide that ongoing help, and frankly where they're going to find their social ties and connections, and they're going to build their own resiliency through their interactions with others. So the emphasis that those exemplary practices are making or pushing is more than a a clinical or medical model that links people to professional services, but that's something that really speaks to people's real lives and what they want, and assures that they have some connection across the community with meaningful relationships and ties. And this is another way of kind of describing these three different components that are being now developed and in different ways by some of those different exemplary programs that were outlined, but underlying all of those, or undergirding all of those, is that recognition that the health practitioner needs to share the general orientation and have a family support perspective, which validates families for their roles, that recognizes their strengths and supports, and that can identify their needs. But in most instances, that practitioner is not going to be the ongoing day-to-day engagement with that family, and they have to be able to provide a warm handoff that's meaningful to others, and that in fact this is an area where by doing so they can also support the development of the programs and family resources in the community that are going to be necessary for those families. So here is, I think, what's different now than I think 15 years ago is there's a much broader array of people who are in the child health primary care practice community and the child public health community, which really do see their roles as this first responder and strengthening families, and that they are good points of referral to the existing family support and family resource programs, but they're also good advocates for the development of further programs and resources linkages. The second thing I think is the child health system itself has found some opportunities for financing some of these family strengthening efforts and linkages, certainly in terms of the kind of the care coordinator community health linkage role, but also in some instances financing home visiting or some types of parenting, parent strengthening interactions, particularly when they're really dealing with dyadic therapies. The third is, I think, that the child health practice serves as a locus in neighborhoods for additional family support programs and activities, that a lot of the federally qualified health centers that exist, and certainly the ones that we've been working with programs in San Diego and Iowa and Phoenix, where not only are those federally qualified health centers doing this broader process and linking people up to community resources, but they're also creating additional family support nights, patient support groups, peer networks within their practice, and they often have this footprint in their communities where they're doing things. And finally, those child health practitioners, as they do this work, are finding that there need to be more in the way of family support financing, and there needs to be more in the way of resource development here, and often can be additional voices for the types of investments that we would like to see made in the public sector. I think I have one more slide, and I really do want to open it up for discussion. So I think that there are opportunities for the work that you're doing now, which is even if you don't have connections with the health system, You're doing great work, and I really appreciate that. But I think that there are now more opportunities for synergy between family support programs and practices and the health field. First is, I think that identifying and building some type of relationship with those exemplary primary health practices and champions in your state create another voice on your behalf and on behalf of kids and families that really do speak to the need for family strengthening in our policies. And most state chapters of the American Academy of Pediatrics, and there are also Docs for Tots groups in some states, are really natural partners and quick studies and eager participants in not just advocating for the health system's role, but advocating for the larger need for more community resources that provide family support, family strengthening opportunities. I think that there's also that increased actions within those primary practices, particularly those qualified health centers, to make their own investments in family support and make their own spaces available and nurture the development of mutual assistance networks or other types of family activity nights and activities that can contribute, that those resource centers often are with faith communities and your own programs, places which families do trust in their neighborhoods and communities and will go to and feel comfortable going to. The third thing is that because of the Affordable Care Act, all hospitals have to do community health assessments at least every 3 years, as well as public health programs having to do those community health assessments. And those community health assessments provide an opportunity to focus attention on what can we do for family strengthening, and to be able to get in, because the hospitals, in doing those community health assessments, are then supposed to respond to what they identify and determine. And I think that there are ways, particularly when P.A.R.E.N.T. work with community health centers and health champions in both public health and in AAP, to really get a focus on, so what do we need for kids in those neighborhoods for their healthy growth and development? And again, the place-based analysis that I provided earlier, you can get that type of information fairly easily for your own community and begin looking at these high poverty neighborhoods. What do they need to have for young children to grow up healthy? What additional resources and supports do they need to have so that those kids have the same opportunities as kids in more affluent neighborhoods have? I think there's a real opportunity to do that work through those community health centers, and then get some of the recommendations that come out financed through the hospitals, because they're supposed to be using those health assessments to finance. And finally, just that collaboration to advance the broader emphasis on health equity in young children, so that policymakers really do see that this is what our future depends upon. Kids are a quarter of the population in our society. They're 100% of our future. And if we're going to have a healthy society in the future, we really have to address children's physical, educational, psychological, and social development. And the parent science says that means substantial attention to the first few years of life, and to the role of how we can strengthen and support families. There are a variety of additional resources from our health equity work, which is on this chart, but I will stop now, and happy to open up for questions and discussions.
Great. Charlie, thank you so much. This is Kaylin again. We had a few people type in, so I was looking to see what their questions were, but there were actually 3 different people who were typing in how fantastic this information was. So thanks to people who shared those comments. That doesn't really give us a question to answer. So I'm going to encourage folks, if you would like to ask a question, you can type it in the question box, and that'll pop up, and we'll be able to read it out loud for Charlie to answer. Or if you are connected with audio and you're in a place where you can speak, you can raise your hand within the webinar, and I can unmute you so that you'd be able to speak. But while we wait for some of those questions to get typed in, I was just going to ask, Charlie, what kind of, you mentioned doing this on the ground in a few different locations. Could you say a little bit more about what kind of uptake you're getting and what kind of interventions people are doing when you, what the response is when you share this kind of information?
Yeah, I mean, I think that the pediatric community is an easy sell. I mean, I think like people who get into early care and education, they got into the field of pediatrics because they wanted to help kids grow and develop. And they really do recognize that, and I say it doesn't take an medical degree to know that mom walks into the practitioner's office and she looks pretty stressed and she's not picking up on her kids' cues for information, and there appear to be a lot of things going on in her life. And you think, and how did she even get the kid in for this well-child visit, given all those other things going on in life? I think that practitioners know that they can do the medical side of the equation, but unless that mom has more in the way of support, she's not. Their children are not going to fare well. So they're really eager for doing things. I think that the big thing that practices feel that they need to have is they need to have somebody who can follow up and do something with that family. That's why the warm handoff to a care coordinator is so important. I think the experience of programs which do this are that some, like medical legal partnerships, focus primarily on concrete services in times of need and do a great job of linking people to those hard service needs and connecting. But those have tended to now move also into providing more in the way of, can we really support the family in terms of providing education about child development if they don't have that? Just supporting, recognizing that they live in, kind of a often stressful lives. Can we find some place where they can go that can really support them and connect up with others like them? The Healthy Steps for Young Children provides a lot in the way of parenting education programs. Most of these programs may start with doing something in the way of a one-on-one intervention, but then end up doing things related to groups or mutual assistance support, because that's what families want. And I think that the programs have moved out in terms of doing that work and creating more in those hubs. I found it very interesting in Maricopa County. They had a real partnership between First Things First and the Maricopa Health System. So they provide primary care through Maricopa Health Systems through 6 satellite clinics for young children in Phoenix, and they've constructed a family resource center, or they provided funding for a family resource center that's co-located at each one of those 6 sites.
That's fantastic.
Yeah, again, I mean, I think that, and I mean, some programs have been able to um, fund and network with existing family support programs and provide not only referrals but some resources to do something with families in the community.
Mm-hmm. That's really helpful. And there was one question typed in while you were speaking, which I think she typed it right as you were starting to speak, and you actually may have answered it, but I'll read it aloud anyway. Iris Davis wrote in, what strategies do you recommend for motivating physicians? And it sounds like you think it's not that big a motivation. One thing that I'll add, and then you can build off of that, is I know sometimes physicians are hesitant to even ask about, you know, they see that mom who's not very responsive to the child, dealing with a lot of stress, but once they ask, they're sort of opening a can of worms that they may not have the resources to respond to. And so I think in a lot of cases when we make sure that physicians know those resources are there, then they will ask the question because they can have a productive response to it. And that's a lot of what I think you already mentioned, Charlie, of making sure there is a warm handoff option and people know what resources are there. Is there anything else you would add about how to motivate physicians?
Well, I would say, and I mean, most of these models have several different components. One is, you know, you don't make a practitioner do it who doesn't want to do it or is really leery about it. I think often, though, peers can really convince them that this is worth trying and it's something to do. We got started in Iowa on one of the, who was head of the public health, who's now a pediatrician practitioner leader, Ed Shore, said, you know, met with primary care practice and said, well, I'm not going to ask you to spend more than 15 minutes. You spend 15 minutes in time in your well-child visit, but can we make that more productive? We're not, I think often pediatricians feel like this is something more I've got to do. So you've got to make sure that you frame this in terms of how you can do it within what time you have available, and that there's going to be follow-up that makes it worth your while to do it, and yet that you're not just kind of locked into doing something that's above and beyond the call of duty. And so the kind of the training and recruitment of practitioners is something that most of these programs have, in terms of not just the practitioner, but the practitioner's office, because often you can do screening in the office and some of the other allied professionals in the office can do some of the work. So that's really important. The second thing is practitioners need to know that if they do identify something, there is some meaningful follow-up. And that's why that care coordinator work and that's what a lot of this, and you can get financing for it through Medicaid and through other supports, but it's necessary that it be fulsome enough that it can respond immediately and help. The experience from a lot of the programs are that the care coordinator, you know, I mean, first is you got to develop some rapport and relationship with the family and understand where they are and what makes most sense for them, and then respond to that. The experience in most of the programs is that they can generally find some point of connection or more than one point of connection that is going to be helpful to the family. They can't necessarily solve everything in the family's life. I mean, they can't necessarily create a new housing situation for a family, but they can do things that respond, and that has a dual role of validating the family's concerns and giving a step forward. That takes some dedicated time, that that care coordinator also then can feed that information back to the practice. So the practice says, oh, so I referred someone and now I found out they were able to get this. Well, that seems to be better than not doing anything at all. So I think that that's a really important component that feel like there can be some follow-up. And as you've worked with families, I know there are some things where if you can't secure there are some families in crisis because of a material or another situation that you just know I've got to do something about it. It's going to be very difficult to do anything if that doesn't change. And there's an imperative to really work around those. There are a lot of situations where the family, there are things that we'd like to see available to all families and that we'd want to see those things in their lives, and it's really something that isn't fair that they don't have, but that are not those kind of life-threatening or just really stopping them from getting ahead and doing anything. Often just providing some help and having families feel like now I can do something I couldn't do before. Now I have a support that's not there before. It's a benefit to them, and it does help to foster resiliency or not. I mean, I think that there's an innate resiliency, but it's also, it has to be nurtured a little bit. But if people feel like I'm now able to do something I couldn't do before, my kid is doing better, my kid has this, that those types of step forward can be really, really powerful, even if you can't get that family immediately into a better housing situation, and certainly can't get that family from a not very good minimum wage job into a family sustaining employment. You can do something that can foster more in the way of hope. And I think that practitioners seeing that and seeing that there's an appreciation that we did something that helped, that families are appreciative, really does keep the buy-in. One of my friends who worked on child welfare reform and did great work, she wrote a master's thesis on the work that they did and really how you could get families out of the child welfare system, and how you could work with them to say, you know, what is it that, you know, you'd like to see in terms of getting free of the system, and how can we make that happen? She did her interviews with a lot of the clients and asked them the kind of the simple question of what seems like help. What was helpful to you? And there were some of those hard services and pointing to, this person was able to get this for me and I wasn't able to get it before. A lot of it was, I was treated like a real person. People validated that what I was doing was, I was working hard to make something happen. That validation and that recognition that, yeah, you're in a tough situation, but you're a good person. That was a lot of the help that I think that often our systems don't do a good job, and that's kind of one of the powers of family support is in being asset-based, is really, as people, if you do feel valued, it just supports you in going ahead. And I always say kids are a tremendous motivator. So even if you can't see something that much better in your own life, if you see that there are new opportunities for your kid and that something's better happening, that's just very positive. And I think that those are things that really around the exemplary practices when talking with practitioners and certainly with the care coordinators and the people in the field who are community resource linkages and other things. That's what they feel positive about doing what they're doing.
Thank you so much, Charlie. I think that's a really great response, and I will say Iris wrote in a response saying, good points. Thank you so much, Mr. Bruner. We at Achieve Escambia and Pensacola, Florida are at the beginning stages of this undertaking. So I think there are a lot of people on the line who are getting good ideas they can apply in their work, and I will encourage people to check out the resources at the Child and Family Policy Center website. And Martha Reeder also had the suggestion that we should try to connect folks with some of the models and some of the ways that people are really getting this going in their community. So we'll keep looking for opportunities to make those connections. And I know we're out of time here. Thanks everyone for staying on a little bit past our ending time. And I just want to thank you so much, Charlie, for taking the time to share this with us. I think a lot of people got some great ideas and some new ways to frame arguments that a lot of us have been trying to make. It's good to have that data to back it up, and the way you frame it is really helpful. So thank you very much, Charlie, and everyone who joined us.
And, continue to be part of the chorus, so thank you very much.
Thank you. We'll all be in touch soon. Take care, everybody.
Okay.
Have a great rest of the day.